Assalamu alaikum wa rahmatullah. Thanks to all professors and members of Pediatric Orthopedic Unit. Special thanks to Dr. Abdullah Nada for his effort and Dr. Ahmed Salah for video recording. I'm Ibrahim Mazrou, an assistant lecturer of orthopedic surgery. Our case today is 8-year-old boy with bilateral Perthes disease. Left femoral head reduction was done. As the x-rays show, there is left central necrotic segment 3D planning was done using the patient's CT. Those images show the 3D model after removal of the central segment and the reduction in spine that occurred in the femoral head. As we can see, the head becomes more spherical, congruent, and can fit well in the acetabulum. The patient is lying in lateral position with the operated side up. We start with about 15 centimeter skin incision centered over the greater trochanter, then superficial dissection by incising fascia lata, separating the tensor fascia lata forward and gluteus maximus backward, then incising the trochanteric bursa and cauterizing the greater trochanteric branch of medial femoral circumflex artery. Then we insert homon retractor to elevate vastus lateralis and retractor to retract gluteus medius and minimus from piriformis muscle. Then we mark the greater trochanter osteotomy site with electrocautery. Then we start to perform the greater trochanter osteotomy using mini-saw. Then we dissect the remaining soft tissue with curved scissors to mobilize greater trochanter and muscles attached to it anteriorly. We then elevate the remaining soft tissue to completely expose the hip joint capsule. Now we can perform Z-shaped capsulotomy. The transverse limb is with neck of femur. The anterolateral limb is at the distal part, and the posteromedial limb is at the proximal part parallel to the labrum of the acetabulum. Now we can dislocate the femur with flexion, external rotation of the hip. We can hang the two limbs of the hip capsule with sutures to allow easy finding and repair later. As we can see, the head is greatly deformed, the neck is very short, and very close to the greater trochanter. Then we reduce the head again and generate the medial and lateral retinacular flap. As you can see, the lateral retinacular flap is well separated. It's the blood supply of the lateral mobile segment of the head. Now we put the 3D guide in its pre-planned suitable place and stabilize it in place with two 1.2 Mercure wires. We then start to perform the osteotomy, depending on the 3D guide, two vertical osteotomy, and one transverse osteotomy. We use mini saw with continuous saline irrigation to prevent heat injury to the articular cartilage. We can use the back of the home-on retractor to protect the retinacular flaps and the blood supply from injury by the saw. We then complete the cuts with osteotomies. Now we have three parts: the stable medial part, the central necrotic part that will be resected, and the lateral mobile part. Now we resect the central necrotic segment from anterior to posterior with a great caution to avoid retinacular flap injury. The lateral segment is now mobile depending on the lateral retinacular flap, so it can be freely mobilized. We then reduce the lateral segment to the medial, making sure that the posterior articular surface is congruent. Then we stabilize the reduction with 2K wires. We fix the head with two double compression screws from lateral to medial. We bury their head inside the cartilage. We then do chondroplasty to the anterior hanging lip. We fix the neck with another two double compression screws. As we can see, the head locks more congruent and the osteotomy site is compressed. We add another prophylactic screw in the stable part of the neck to prevent iatrogenic fracture. That fluoroscopy image shows drilling for the prophylactic screw. It also shows the screws of the head and neck. Preparation of the lateral femoral cortex by removal of cortical bone to prepare the bed of the greater trochanter. Drilling the lateral part of the femoral head by a very thin K wire to assess head vascularity and viability after reduction to the acetabulum. Now we can sew the limbs of the Z-shaped capsulotomy with absorbable sutures. We then distalize the greater trochanter and fix it with two screws on washers. That fluoroscopy image shows the final fixation after distalization and fixation of the greater trochanter. The greater trochanter is almost at the level of the femoral head center. Now we use the mini saw to remove the protruding lower ing of the greater trochanter to prevent it from being very prominent. Finally, we irrigated the wound with saline and closed it in layers The final X-rays show reduction of the head with better containment compared to the pre-operative radiographs. Clinically, the patient abduction and external rotation range of motion has improved. At the end, we hope that our video would be helpful. Thank you all.